I've divided my talk into two parts. One is the role of coronary CTA and ACS, and the second will be the role of echocardiography in the same clinical setting. Before I start, I think it's a great initiative by Philips to get us all together in these very troubled times. And I think this kind of situation is going to stay. So I think it's very important that we get comfortable with the technology. And we are also really fortunate that Philips has made great strides, especially in cardiac imaging. I know they do a lot of work with the intervention people as well, but just want to thank you for enabling such sessions and hope we have more of these in the coming days. So we'll be talking about coronary CT. The clinical problem, as you all know, is that chest pain in the emergency department is a very, very sometimes challenging and difficult problem to resolve. ECG changes, again, in a good majority are either missing or they are very minor. Can't really take a decision on that. We really need to wait for that troponin because the troponins take about an hour to come in, and we know based on the dynamics of troponin that it takes about 4 to 6 hours for the first rise of troponin, especially in these kind of patients. We're obviously really not dealing with STEMIs. We're not dealing with high-grade unstable angina, non-STEMIs. We're really looking at those patients with the typical to atypical chest pain, patients with what we call intermediate risk of coronary artery disease, somewhere in the 8 to 15% 10-year group. And these are the challenging patients that come in, and really whether it's an ACS or it's an atypical pain needs to be resolved. So the background of this is we have the US data, and almost 8 million visits to the emergency department per year because of chest pain. Second most common reason to visit the emergency department. I'm sure COVID is sort of usurping that position right now. Anyway, nonetheless, when you look at these patients, only a third really have coronary artery disease among these 8 million people. And it's only really 4% having the low to intermediate risk patients that we really want to be looking at. The unfortunate part is that despite all our due diligence, we send back almost 4% of those patients with an ACS back home. So it's in these troubling statistics that we're trying to interpose a technology in this very difficult subset of patients to see what we can do with it in terms of both accuracy, non-invasiveness, safety, and most importantly, time sensitive and cost effectiveness. So as she was mentioning, I don't really deal with a specific technology. I don't have any preference. We've been lucky for the last decade or so at the care group at Hyderabad. We've had access to PET, nucleus gamma camera, and a CT, as well as a cardiac MR. Really no preference for any technique, but what is important is we've been able to work together with our people in the different areas, nuclear medicine physicians, radiologists, and intervention people to evolve strategies that allows us to put in technology or pieces of technology in the pathway, clinical pathway, so that it serves the population very well and also serves the physician who's asking the clinical question. So that actually is my expertise rather than being a technical whiz kid on a high-end CT. So with these facts, the options obviously are when a patient of that sort comes in, do you want to hospitalize him, put him in your CCU? You don't want to take that risk of 4% sending back. Recently, of course, we've been dabbling with the chest pain units, low-cost areas, adjacent to the emergency rooms where you can safely keep a patient at a low cost with very minimal infrastructure resources for 4 to 6 hours till the second troponin starts sort of happening, and the second or third ECGs are also negative, and then maybe safely discharge that patient or decide to admit him depending on the case. We have been looking at using the treadmill or a nuclear scan with a treadmill or a nuclear scan with an adenosine in these daycare patients. It happens only in the daytime, wherein if you find the pain is totally atypical, drops are negative, ECG normal, You want to do a stress and send him home to be sure, but this is fraught with danger as I said, 4% may be having an underlying ACS, and you don't want to rupture that already 90% plaque and send the patient to the cath lab. And believe me, in the last decade, I have actually done that. And patients, I have to just send to the cath lab and do the angioplasty for these patients. So we're sort of moving away from doing treadmills and nuclear scans in acute patients. And of course, the last one is the one which most of my colleagues would like to do. That is, do an angiogram and be sure, because the angiogram, as we know, is a gold standard procedure, and do it and then only send the patient. So these are the options in front of us, and these have been the conventional options for quite some time. Now, when you interpose CTA in S, do we have the evidence? And yes, we have about 4 major trials, and ranging from about 200 to about 1,500 odd patients, where 50% of patients went through a CT and the other 50 went through usual care. And we have found about 4 to 5% in a meta-analysis of patients actually had a stenosis of more than 70%. And the follow-up has been anywhere between 1 and 6 months. And the follow-ups have clearly shown the safety of using this technique in the acute coronary syndrome patients. On the technique part, we know that the cardiac CT, the technique that you use is basically based on the weight and the heart rate. If you have a dual source scanner like we have with the Siemens, if you have a lower heart rate, less than 60, and a weight less than 90, using a dual source high pitch scanning with prospective ECG synchronization is the way to go. And we get away with 2 to 3 millisieverts of radiation exposure. However, if the heart rates are more than 60 and the weight is more than 90, then prospective ECG triggered axial scanning is done. That leaves us with a 5 to 7 millisievert study. But if the patient is obese and the heart rates are high, then we have no option but to go with the retrospective ECG gated scanning. And many times this is done when we're also looking at imaging other structure. For example, you're looking at a triple rule out, for instance. Now we've come a long way with radiation, and you can clearly see the journey from 2004, from almost 20 millisieverts. We have come a long way, and the high-end scanners, dual source, flash, we're able to do in about a millisievert right now. But I think the average operator would be anywhere between 5 to 7 millisieverts, which is still a far cry from the 20 plus millisieverts that we're doing when we started this program in 2005. So radiation continues to be an issue, and using various tools like modulating the radiation based on the weight and the iterative reconstruction and all the gadgets that are now available with the latest CTs, we've been able to really cut down on the radiation to a great extent and make sure the procedure is as safe as possible. Now, I would like you to pay a little attention to the schematic here. And this is a publication from 2006. And this is essentially what many of us have been doing in cardiology in symptomatic patients with coronary artery disease. So as we come down, remember this is for symptomatic patients. So if they have a low pretest likelihood, that is 1.5% per year or less, then these patients are managed medically. They really do not have any reason to undergo any kind of imaging. In the intermediate risk is where we find that there is a big role for imaging technique like CTA. And here we find that if you have a completely normal scan, then this patient can be discharged early and he gets to have primary prevention. In fact, possibly the greatest role of CTA is in this group, wherein if I'm able to give a normal study for a patient, there is no non-calcified plaque, the calcium score is 0, I'm not looking at a dissection, there is no embolism, and there's no non-calcified plaque, no lesion at all. This patient is absolutely safe to go, and this is where CT really shines in that there is a 99% negative predictive value that is available with the technique, is a good study, and this is the kind of patient CTA really shines with. In patients who have an abnormal scan that is clearly more than 70% on CTA and involving the proximal third of either the RCA, LAD, or the LCX, then these patients would directly go to the cath lab. There is no question. Along with the stenosis, we would like to give an estimate of the plaque vulnerability, whether there is a napkin ring sign, whether there is non-calcified plaque with low HU units suggestive of lipid core, whether there is some spotty calcification. All these things need to be added in the report, and they would go to the cath lab and get fixed. In those, and unfortunately, this is the majority of patients who have an equivalent kind of a picture that is anywhere between 50 to 70%. It's not really mild, it's not normal, it's not critical. Then the practice is to go ahead with a SPECT scan, and the SPECT is generally done with adenosine. It's pharmacological stress, vasodilator pharmacological stress, and that limits the complication than when you do an exercise stress technique. And here, obviously, if there's large ischemia, more than 10%, they go to the cath lab straight away. If there is no or minimal ischemia, they are managed with secondary prevention because there is disease, and they get secondary prevention with high dose statin, beta blocker, and aspirin. And again, if that is also borderline, then they would go to the cath lab and get fixed. So this is a sort of a bird's eye view of how we would generally triage patients in a high dependency unit or in an ER or in the outpatient setting when patients would come with chest pain. So 4 randomized controlled trials we have in the emergency room looking at CTA-driven management versus usual care. The first one I'd like to talk about is a CT STAT trial, which was a multicentric trial, and one of the authors, Dr. Johann, is a good friend of ours, and she comes regularly to India and chairs several meetings on the imaging front. She works at Michigan. So here are 6,000 odd patients screened, but only really 750 enrolled. So that's the challenge of trying to get the right patient for your study. So you can imagine it's only 10% really of your patients that you can really look at. But nonetheless, both were equally enrolled for CTA on one side and standard of care on the other. And the same rules, non-obstructive early discharge, severe goes straight to the cath lab, and an intermediate range would have a myocardial perfusion scan. If it's abnormal, you get to the cath lab, or else you're managed medically. The standard of care, the ones which are normal, TROP-Ts at negative, no further ECG changes, you would get early discharge. If it's abnormal, very significantly, in the sense TROP-T is high, ECG shows ST depressions, patient has ongoing pain, again would get fixed. TROP-T is at borderline, second TROP-T is negative, ECG, no significant changes, they would then get the CT also, and if it's normal, they get discharged, and if it's high-grade stenosis, angiography. So this was the design of the study. And if you look at the event rate, both the groups are fairly evenly matched in terms of outcomes, really. And even the procedures were very equally matched. Then what was the real difference? And the post-operative rates were also very similar in terms of the hospital follow-ups and the death rate. But when you look here, you will see that the CT group really shined in one aspect, and that was the time to diagnosis. 3 hours on an average compared to almost double the time which was standard of care. And this was statistically significant. So time is money, and here you can clearly see CTA giving you that advantage of getting to a clear diagnosis on time rather than waiting around, second ECG, second drop. All these things take time, trying to mobilize a patient for a myocardial perfusion scan, and the difficulties in the night to do that. Now, the second thing which also happened was the very good cost effectiveness. The emergency room cost was significantly less when you interposed a CT very early on in that group compared to having it done late or going through the standard of care. And then if you look at the MACE, it's able to achieve all this with a similar MACE. That means you're able to get to your diagnosis early, you're able to get to discharge early, you're able to do it in a cost-effective manner, and the most important thing, you don't sacrifice accuracy for that. So it was a great trial. It just heralded the next couple of trials. And the next one, 2012, by Udo Hoffman and Pamela, was a ROMICAT-2 trial, which was in the background of the plain ROMICAT observational trial. And again, clearly showing you that only a small minority of patients who were screened for ACS actually had ACS, 8 to 10%. And again, 1,000 odd patients, 1:1 ratio. And basically here looking at hospital stay, because we clearly knew from the other trials that the accuracy and the safety was quite good. But clearly showing you here that proportion of patient discharged were very early, in about a mean time of around 8.5 hours, and it took almost a day for the standard of care patients to really get discharged here. You can see that for discharging 50% of patients, it took more than 24 hours in the standard of care in red, where the same thing was done in 1/3 of the time when you interpose CT very early on. And what they really showed was the time to diagnosis again was really low in CTA. Time to diagnosis made the average hospital stay also low. It made the discharge much earlier, much faster, and the readmissions were less. And most important, you did all this with a very good accuracy, as good as standard of care, both at the immediate and the 30-day. Adverse MACE was similar. And again, you get to do this in a very cost-effective manner that is almost 20% less cost per patient. Now, just moving on to the mechanics of the the thing is that when we see these patients, we get the CT done. We always in our center do a calcium score. In the West, many people avoid doing a calcium score because of radiation issues. But we believe the calcium score has so much to tell in terms of picking up an intramural hematoma, for example, looking at the density of calcium, looking at the spread of calcium. So, for example, if I have a patient who is crossing 1,000, for example, on the calcium score, very extensive plaque burden with chest pain, I'm really not going to be sitting around and waiting to do the CT. I will wheel this patient directly to the cath lab compared to a patient who has maybe a borderline 100 to 150 score, wherein I would like to look at the position of the calcium. That means if I have a significant left main calcium, ostial LAD calcium, I call it the surgical area, even if this patient has an under 400 score, I may not go ahead with a CT on this patient, and I wheel this patient directly to the cath lab because the chance of finding surgical disease is so much more in this patient. So the calcium score really sets a trend of how, as an operator, I would like to really look at this patient. And again, if the patient is more stable, high score, I would even go ahead and do a nuclear scan with adenosine. May not proceed with the CTA because if I find the calcium is overwhelming, I would just like to see if there's ischemia. If there isn't, then I would like to go ahead and discharge this patient. So calcium score really setting the trend. However, we must realize that calcium score in the ER is not a great thing, in the sense the probability or the prognostic capacity of calcium is pretty low in the ER, as you can see. that even if you have a calcium score of 0, unlike in a normal patient who comes in the outpatient, you're really not protected in terms of atherosclerosis or stenosis because there is a high incidence of non-calcified plaques in the patients who report to the ER. So just with calcium score, you're not going to be making the decision of discharge. You need to do a CTA. This is again clearly showing you that the high value of a 0 calcium score in asymptomatic is clearly not the case in a symptomatic patient, which is where an ER patient is. And clearly, a calcium score of anything more than 0 has a increasingly bad prognosis compared to somebody with a 0 score. So I'll just take you through these cases. Any questions up till now? I would prefer to answer the questions at the end, if that's okay with the moderator.
Yeah, sir, sure. So we will open the chat window 5 minutes to 9.
Yes.
Yeah.
You can also just guide me when to stop, just so that I'm not overshooting the time. So we have enough time for discussion.
Sure, sir.
Yeah. So this is a 38-year-old male, atypical chest pain. Well, he's a smoker. He came in and ECG normal. There was the troponin T was 0.004. And I just decided that the patient was very anxious. We went ahead with the CT. You can see the calcium scores 0. Good prognosis. We went ahead, did the CT, pristine, clear coronaries. And you can see that there is a superficial bridge in the LAD. RCA is absolutely clean. And this is the circ, again, clear. So yes, this patient was declared to have normal coronaries, TROP-T was negative, ECG was normal, discharged within half an hour of the scan with good hydration, kept on a beta blocker because his heart rates were quite high when he came in, and obviously given a little chat about decreasing or stopping his smoking. Another patient, 45-year-old diabetic lady, atypical chest pain. She's diabetic for the last 5 years on oral drugs, not on insulin. Varying control, HbA1c ranges between 7.5 to 8. Again, we decided the ECG was showing some changes, but we had a look at the old ECG. It was sort of similar. Troponin T was borderline. Our cutoff is 0.20. Her troponin T was 0.09. So it was sort of in the borderline range. Went ahead with the CT, calcium score was 2.3, again low for her. And again, you can clearly see that the coronaries, just for a mild area, were almost clear. It's a very mild disease. So this lady was counseled for better sugar control. And she also was started on aspirin because of her calcium score and that mild lesion there, and also put on high dose of statin. She was called after a week to get her lipid profile checked so that we could modulate the statin dose to keep that LDL under 100, as is the recommendation once you have atherosclerosis. So next patient, 54-year-old lady, exertion chest pain here. Now this is a lady whom did not have any risk factors, and the exertion pain was of less than 1 week. There was no rest angina, and she came in the night. There was a part of me that was saying that, you know, we should take this lady to the cath lab, but she was clearly not keen. The family was not keen. So with really not much options, I offered them a CTA, which readily took. Again, showing you that the CTA is a very easy technique to accept for the patient. It's quick, it's fast, it's non-invasive. You get the results immediately. Patient can actually walk out if required, compared to if they have to get admitted and go to the cath lab. So again, some of the more subtle areas where CT can help. And here we got a calcium score of 227, majority which was in the RCA, and here you can see that there is a borderline lesion of 50 to 60% in the proximal RCA. The other vessels were normal. And this lady, I then admitted, and she got her heparin and her aspirin and clopidogrel loading doses. We did the cath the next day, and we did find a 70% lesion, which we fixed. I did a plasty during the same time. And obviously, our strategy was very clear because we had seen the lesion, measured the lesion, we knew it was discrete focal. So we were able to counsel them in terms of finances, what to expect, so on and so forth. So that made it very, very easy. Another patient, 67-year-old gentleman, diabetic, hypertensive, COPD, so multiple risk factors, elderly, male, you have all those things there. Atypical chest pain again, comes again odd hours. This is the first time he's been having it for the last possibly 2 to 3 days. And he's a little breathless as well. Not sure whether it's because of the COPD or is there a significant coronary artery disease. So we went ahead, did a CT, again here, high calcium score, 1609. This is the kind of patient that I would have liked to have stopped and sent to the cath lab, but the pain was atypical. Again, patient wasn't keen on getting an invasive procedure. And my strategy, this is just a personal strategy, is that rather than admitting these patients for a night, we charge them roughly between 18 to 20,000 in a step down situation. I would rather have the diagnosis up front. So the CT again really shines in that you get that diagnosis within about 10,000 rupees, and that really sets the trend of not only having what to do with the patient medically, but also helps you in getting the crowd support, family support in enlisting your choice of treatment. So yes, despite my misgivings about the 1000 score, which I told you I would like to go ahead with either a nuclear scan or an angio, we went ahead and did the CT, and we did get away because the calcium was far and in between, and mostly concentrated in the LAD, and the left main was clear, so it was clearly not surgical disease, and the RCA and L6 had mild disease. So yes, we admitted this patient. The patient was not willing to undergo a revascularization, so we kept him on optimal medical therapy. And if you look at the ischemia data, and we were part of that large ischemia study, which recently concluded, which was neutral for both revascularization and OMT. I was a PI here, and also our lab was one of the core labs that was used for CT. And I must say that CT again really shined in the trial. For those of you who had had a look at it, it was responsible for ruling out all the left mains. And that really made a difference, because if you could take out left main from the equation, optical medical therapy is a very good option in a patient with a triple vessel disease. So here we kept this patient on optimal medical therapy, and he continues to do quite well. Yes, this was another patient, again presented with atypical chest pain, calcium scores with high, and yes, we had significant lesions. This is the LCX, LAD, multiple lesions here. And in this patient, this was the patient who came in the daytime. The symptoms were very atypical. So we went ahead and did an adenosine test, an adenosine maybe, using a sestimab, technetium sestimab. And here you can see that the rest scans are perfectly fine. So there's no infarct, good LV function. But in the stress on adenosine, we found that there was a mild defect in the infralateral zone, and suggestive of a mild ischemia. So this is to show you how we interpose a functional study in these patients. Now, this was another patient wherein you can clearly see here, 47-year-old gentleman, chest pain, again atypical, he was a smoker. So yes, we did the CTA, got a high-grade stenosis, and we found that this was a vulnerable plaque. It was non-calcified, lipid-rich, low Hounsfield units in a very critical area of the proximal LAD, and the angiographic, and this patient was obviously wheeled to the cath lab, and you can see the angio corroborates clearly the CTA showing accuracy is really not a problem in today's scans, and he was immediately fixed with a stent across the LAD with a good result. What is important, as I previously did allude to is that when you're sending these patients with the report, we are not only interested in the stenosis, but we are also interested in this stuff, which is basically the wall. We really want to be looking at it very clearly, looking at the low Hounsfield units, the napkin ring kind of sign here. We also want to look at the spotty calcification, which is there in the periphery. We also like to look for positive remodeling in the vessel. So these are some of the plaque characteristics I would urge all imagers in this audience to please look at very carefully, not only talking about the calcium score, not only talking about the stenosis, but really looking at some of these lesions in depth. And we have good tools now. The IVIS, we call them the CTA IVIS tools. It's there in most of the manufacturers in the software. Look at it carefully, identify the non-calcified rim here, and a little bit of calcification. You need to do a little bit of window leveling to see this. You need to do a little rotation because sometimes it looks okay, but when you rotate it, like how you rotate the vessel, you see the underlying positive remodel lipid core. So I think these are important things that we must pay attention to while we give that report out. Now, just switching gears here, CT also is very great in the emergency department, wherein you're also able to look at this sort of difficult subset of coronary anomalies, and sometimes they do come in young patients, chest pain, and this is one of our patients who had the left main coming from the right coronary cusp, and this is a very difficult subset to catheterize. I must tell you that it becomes very difficult in the cath lab, and you just cannulate the right coronary, you don't find the left, you're really searching a lot of time contrast. So CT gives you that picture. It also gives you whether it's malignant or benign. Here it is crossing the MPA, so this is something that really needs to get fixed. This is a more common anomaly that most of you are used to, and this is the right coronary artery coming off the left cusp, and also with an interarterial course between the main pulmonary artery and the aorta. What is also important to note is the angle of origin, if it's acute, and also if there is a slit-like orifice. Now, these are the two additional points I would like to add whenever you give this report, because they also really add on to the malignant nature of the vessel. The other thing that I would just like to add on is that we're also looking at the origin of the RCA. Now, if it is higher up, it is exposed to the muscle of the pulmonary artery and the aorta, and generally in our series of about 15 patients, they tend to have positive nuclear scans. Whereas if the RCA is a little below, that is coming at the fibrous origin of the aorta and pulmonary, with exactly the same configuration, these patients actually have negative nuclear scans. And I have about 8 of these patients with so-called malignant RCAs. I've just kept them on beta blocker and statin, really not send them for surgery. And part of the theory, I believe, and this has also been reported, is the height of origin makes a difference. If you come from a lower height, you tend to get a little protection. And this is again a benign abnormality where you see the left circumflex coming in from the right coronary cusp, and then having a retroaortic course being sandwiched between the aorta and the LA, which is okay because the LA is a posterior fixed structure, so there's really no compression here, and it's a benign anomaly. Now, in patients with ACS, the next level of therapy obviously will be to do an FFR on them. Right now, we are sending our cases to HeartFlow, which is in California. We're getting the results in about 24 hours. We upload it onto their website, and we have an agreement with them. But I believe in a year, we're going to have this at our desktop. I think Siemens is in the forefront, and I'm sure Philips is also working on a solution. The HeartFlow people are also now in mainland US giving reports within about 4 hours. So if you look at the platform data, again, there's a study by Pam Douglas, you could clearly see here that when you interpose a FFR CT in a patient with a chest pain syndrome, not only you get an earlier discharge, but you're able to get away with a lower cost. And remember, these are all reimbursed patients, so it's entered the realm of reimbursement. That's a good thing, especially for patients from mainland US, where you're able to get away with a faster discharge time, and you're able to get away with a lower cost. So FFR CT in your CT console is going to be a reality within a year or two. And in borderline situations where we would do adenosine scans or send them to the cath lab or admit these patients, add another 20,000 bill to them, with another 4 to 5,000 extra, you could have the FFR CT, and if it's negative, they're safe to go. And we know how FFR is so robust. If you have an FFR of more than 0.8, it means the patient is fairly safe, and there is good data in that direction. And this is just to tell you that there's a very nicely studied group wherein in the usual care, all patients went through the cath lab, and you can imagine that 7 out of 10 actually had non-obstructive CAD. And it's remarkable because in COVID times, I know how difficult it is for me to get into my PPs, enter the cath lab for a simple angiogram. So much of risk to the operator, the nurse, the technician. Here, when you use the CTA and FFR interposed on these patients, you can clearly see that you have a solution for 60% of the patients, and only 40% really have to go through the cath lab, out of which again one has non-obstructive CAD. So not only is it quicker, is it cost effective, but in COVID times, it's a hell of a lot easier. And what was clearly shown when you did CT and you did an FFR guided strategy is that you didn't miss out on the interventions. You had equal interventions in all the arms, so you're really not missing out doing anything on the patients. But what is really important is that you're getting away with a lot of unnecessary tests like echo, nuclear, by just needing to do a CT, and also a lot of angiograms being done in these patients, which is radiation and cost. And most importantly here, especially in the invasive arm, there's a tremendous cost when you use angiograms or coronary angios up front compared to having a CTA strategy. Well, we all know the benefit of the triple rule out. We don't promote this aggressively, but yes, in those patients where you're looking at a triple problem, you're not sure, patient has a little bit of breathlessness, troponin T borderline positive, BNP is positive, not a clear coronary patient, some mild leg swelling, which you're not sure. So CTA is a great tool, and here you can clearly see aortic dissection, it's proximal dissection, type 1 dissection. It's a false lumen, RCA coming off the false lumen, the left coronary again coming off the false lumen, very good for diagnosis, management, immediate surgical therapy, thrombi in the right pulmonary artery, and the very grossly dilated RARV, everything clearly seen on the CT, very helpful to make a diagnosis, very helpful to take a management, to have a management strategy, and also very importantly, have a very clear prognosis for these patients. It does come at an increased cost of radiation. It comes at a cost of increased contrast. So yes, the ER physician has those has that huge responsibility of ensuring that the right patient really needs a triple rule out, and not all patients with a chest pain syndrome should get it. We also, as imagers, whenever it is possible, we try to make sure that we are in sync with the clinician, the ER, or the referral physician, that do we really need to do a triple rule out? Can we get away with just having a CT coronary? Now, just to summarize, clearly you can see that what really shines through CT is the high negative predictive value approaching 100%. And the negative predictive value, again, excellent here. Positive predictive value is low, agreed, because of the calcium and other issues. And the negative predictive value, again, continuing to shine. And again, here, the incidence of having an angiogram, if it's CTA driven, again, is higher. We pick up more patients when we do that. The incidence of revascularizations, again, is higher if it's CTA driven. That also does increase the cost, and that's what is being shown. But basically what it means is you're not missing patients to revascularize when you use a CTA. What is again very important is that it does all this with good accuracy, no compromise on the post MACE, as I must say, compared to usual care. So we are right there with usual care, but what it really does, and that's the gold standard, decreasing the length of stay, time to diagnosis getting reduced, and also showing tremendous cost advantage. So just to summarize, calcium score CTA have a high negative predictive value. Zero calcium score, CTA normal, you don't have any ACS, you can go home early. Low predictive value means that if the CT is abnormal, that does not mean it's ACS. You need to clarify it if the high-grade lesion is there by an angio, or if it's moderate, you need to do a nuclear scan or a doveamin echo. CTA-driven management means very good outcomes, as good as standard of care, but it comes at a lesser cost with a shorter hospital stay. So in the recommendations, it has a very good recommendation as a 1C recommendation, because we just don't have enough data. The numbers are low. We don't have a large randomized controlled trials, but we do have observational trials. And as an alternative to exclude ACS, where there's a low to intermediate likelihood of CAD and troponin ECG are inconclusive, again, it's a 2A recommendation, which is still pretty good. And the B level of evidence is again quite reasonable for these patients. For 4 trials, I think a B recommendation was quite reasonable, and that's where we stand today. And this is just to sort of summarize the whole talk. Patient coming with chest pain, non-cardiac, gets discharged with appropriate medication, possible ACS, low risk, low pretest possibility is a coronary CTA, and then you can have no coronary artery disease, mild disease, moderate disease, which needs to be differentiated further by an admission, nuclear scan, or if it's severe, go straight to the cath lab. High probability ACS really needs admission and goes to the cath lab directly. So going to shift gears. We have about 15 minutes, and I'll quickly talk about echo in the ER, which is sort of a similar tool. Who are we going to image? Yes, it's the uninterpretable ECG patients, especially LVBB, especially when you don't have a prior ECG, non-specific STT changes. The majority of those patients have it. They're either on digoxin, they're on drugs, they're hypertensive, so on and so forth. They have borderline biomarkers, so really you don't know what's going on. And the presentations are very variable. Ischemia, infarction, dissection, pericarditis, myocarditis, big list out here. So echo really is able to sieve through. And what is the information that we really get when we use echo? Well, we get a diagnosis. It helps us in decision making, looking at regional function in terms of location of the ischemia, location of the infarct, extent of the LV dysfunction. In a patient, it also looks at global function. In a patient with a low blood pressure, are we looking at a hypovolemic shock with a normally collapsing IVC, good LV function, normal filling patterns of the mitral valve? Or are we looking at a patient with a good ejection fraction, but a patient who is tending to go into pulmonary edema with a high E by E prime, or a very dilated IVC with poor collapse? Whether this patient with a severe dysfunction would benefit with an IABP. The third area it really looks at is prognosis, early prognosis in terms of the LV function, size of the LV, and the global LV function that will tell us what is the early prognosis. And late prognosis is if you can add on a stress test, either with dobutamine, where we can clearly see if this patient can return to work immediately, or does it require to be in the hospital and get fixed. And lastly, any complications of the ACS. So echo again addresses a lot of issues, and it's able to fix a feature for each one of these very similar presenting pathologies. And what is again very good is, like CTA, it has a very good negative predictive value when it looks at regional wall motion abnormality. And but the specificity again, like CTA, is not great, because for the same regional wall, it could be CAD, it could be non-ischemic, myocarditis, LVBB, post-operative patient, and varying thickening of the myocardial wall, whether it's an infarcted patient or patient with reversible ischemia. Now, the data has been quite good. We have been having data for the last almost 20 years. And echo again shining through in terms of sensitivity, more than ECG 93 was 30%, not only for the diagnosis, but for predicting the hospital complications. And again, data showing you that if you have a good LV function, the prognosis is much better than if you have a poor LV function with high, the mortality rate is extremely high. Again, this is data from the American Society, clearly showing you that in a patient with an ACS, if you have a normal echo, event-free survival is in the high 80s, whereas if the echo is abnormal, it comes down to 50% survival. And when they looked at a lot of things, age, T-wave, troponin, again, negative predictive value is really quite high with the echo. Not a very good predictive, positive predictive value, but again, like CT, high negative predictive value. And again, clearly showing you that echo is very sensitive to very high negative predictive value in acute chest pain situations. And these were two patients, one with the normal coronaries, and I'm afraid the video is not playing, showing you a good LV function. And there's another patient who comes with a pre-existing LV dysfunction, not a known MI, but there's regional wall motion here in the LAD territory, and clearly showing you that this 51-year-old gentleman needs to be admitted. He needs evaluation, he needs an angiogram, cannot be sent away. Now, what about biomarkers? Do you think they could be replaced? Well, we're doing a lot of work with biomarkers, and at present, the consensus is that they're complementary tools, they're synergistic to what the ECG and echo can offer. And while ruling in by troponin is easy, so if you have a positive troponin, yes, you get to get admitted. But if you have a negative troponin, you need to wait because the patient could have come early. We know the troponins peak by only 6 hours, so an early troponin negative really does not mean anything. So we need to have it to be repeated. There's always a question of whether troponins replace the echo. It's there in heart failure as well. If you look at the European Society, it's PNP versus echo. The American Society, it is troponin versus echo. We don't believe so. We know that the sensitivity is low for troponin, while the sensitivity is very high for echo, while the specificity of troponin is much higher. So both together, you can get a very good sensitivity with a fairly decent specificity. Of course, high sensitivity troponins will change the game, but again, you can clearly see that it still takes about 2 to 3 hours for the troponins to peak, even the high sensitive ones compared to the low sensitivity. So that's the time where an early echo can really help. So I don't believe that the troponin can really replace the echo. The echo and the troponin are both complementary tools. The troponins do not correlate with ejection fraction or regional wall, which we have realized are very important parameters. And there are other non-specific diseases which can also increase troponins, like a PE, myocarditis, acute kidney injury. And these are situations where echo is completely non-invasive and can really show you that. Well, we're moving on to handheld echoes, and the devices are getting more miniaturized. And this is Boston experience showing that there's a very good yield in terms of ER physicians getting trained, so you don't have to run to the ER every time. There's a good yield in hypotensive patients where a normal echo clearly means that it's hypovolemia as the cause. And the sensitivity again really shines through, really reaching 99%. What about doing stress echo in the ER? And this is data from Bedetti's lab, published about 10 years ago, clearly showing that if it's done well, in a patient with a borderline trop, good LV function, ECG not showing a STEMI, well, you get again a very good sensitivity and a low 13-month MACE if the test is negative. And again, clearly showing you that the data is good if you can do a pharmacological stress, and it will help in lowering the cost of care. The other technology that has come in is the contrast echo. And again, this is a great technology because you do not need to use a pharmacological stressor, and it's very, very safe to use. And these are contrasts which actually do not cross the pulmonary barrier. They're able to cross the pulmonary barrier, so that's the reason why they're able to be used, and they can come onto the left side. And clearly you can see here that the wall is not very clear here. And when you give the contrast, it opacifies the LV very well. And then it clearly shows that there's an area of hyperperfusion in the LAD territory, showing that there is possible ischemia in that area. So again, just to reiterate that, again, this is about 8 years old data. The contrast echo is safe, it is cost effective. And if you have a normal myocardial contrast echo, then the event rate is going to be low and these patients can be safely discharged. So just summing up, echo is a great tool. It's got mobility, rapidly can be moved around from the cath lab, surgical ICU, CT ICU to the emergency room to the cardiac ICU. No problem about mobility, can be brought in with a sick patient. There's no radiation. There's a real-time assessment of a patient. The entire spectrum of heart disease can be evaluated by a good operator. Ischemic heart disease, non-ischemic heart disease, pulmonary disease, PTE, dissection, especially with a type 1 dissection involving the proximal aorta. The interpretation is generally rapid. It can be done. There's no processing involved like CTMR, and a fairly well-trained ER doctor or a cardiology fellow can really reach a diagnosis fairly easily. It can be repeatable by another operator to confirm without any problem in terms of logistics. You don't have to take the patient into the magnet. You don't have to have radiation again. And it's obviously the lowest cost in terms of any of the corresponding cardiac imaging tools, and very easy to train. And we've been involved in the last couple of years in training our cardiac anesthetists so that they can do the transesophageal echoes for patients with valvular heart disease and a patient with severe LV dysfunction in the theater or patient with valve disease, especially mitral regurgitation. And we've also been successful in training our ER physicians also. So it's a very rapidly assimilable tool. And I would say that troponins, echo, and cardiac CT, they're all one family. And just like any good family, they all play very synergistic roles. They're all safe. They can be used in different environments. They have a very good sensitivity. And when they are used together, it's going to be very difficult for any of you to miss a patient with an ACS. So yes, transthoracic is a very feasible technique in the ER, rapid evaluation for a variety of symptoms. And especially if you have a non-diagnostic ECG, confusing clinical presentation, it's a great tool to be used. And the greatest value like CT is a negative predictive value. Thank you very much for your patient listening.
Thank you so much, sir. It was a wonderful session. We have a few questions that have come in. Can I read them for you?
Yes.
So the first question is from Dr. Lokre. He's asking, what is your protocol for heart rate control for semi-urgent or urgent procedures?
Yes, so heart rate control in that situation is we need to examine this patient, make sure you're not dealing with a wheezy patient. So COPD, significant asthma requiring inhaler drugs, or patient coming in with the asthmatic emergency. So these are patients clearly we want to rule out first. Once you've ruled them out, and depending on how urgent the situation is, I just take them onto the table straight away, give 5 milligrams of IV metoprolol with blood pressure monitoring. We have a blood pressure online monitor in the CT room. And provided the blood pressure is above 100 systolic, I give 5 milligrams of IV beta-lock, that's metoprolol, short acting, and then watch for about 5 to 10 minutes. I like to have a heart rate of under 80. I have a dual source Siemens, so pretty okay with high heart rates, but still I like to get that heart rate under 80. In those patients who cannot have a beta blocker used, as I mentioned, COPD patients, significant V's on clinical examination, and that's really key to examine these patients because he could be COPD, but he could have clear lungs, in the sense he could have a very stable lung disease. So in that population, I've been using IV diltiazem. Again, it's about 5 to 15 milligrams IV. I give aliquots of 5 mg on the table, and it works quite well. For those patients where it's semi-urgent and I have about half an hour, I give ivabradine. The dose is 5 milligrams. And if the patient again does not have a wheezy chest, I give 25 to 50 milligrams of short-acting metoprolol, which is beta-log, that's what we use. Along with that, there is also preparations with combinations of the metoprolol with ivabradine in the market. 5 milligrams and 25 milligrams combination is there. So you can also just give one tablet. I wait for half an hour and take them in. Also make sure I give an anti-anxiety pill like Alprax, especially if I find that the patient is a little anxious. So that also helps. So this is basically my protocol.
Sure, sir. So Dr. Lokre is also requesting you to comment on role of CTA versus MRI in acute chest pain.
Yes, so MRI, we have been doing with various whole 3D protocols. We've been looking at coronaries, but clearly I do not use cardiac MR in the acute situation for a coronary evaluation. I really don't use it. The literature also is extremely sparse. With the current generation of CTs, really, I don't want to be taking this patient to an MR suite. CT is just so good. The radiations are so low. The quality is great, and we just get it done with. So really, as far as I'm concerned, no way we're taking this patient in for magnet.
Sure, sir. So the next question is, can coronary CT angiography be used as a screening tool for high-risk individuals? Do you suggest that?
Yes, obviously. I mean, we are obviously talking in the acute setting. And the way we use it is any patient comes with a very significant chest pain, clearly ischemic, ECG changes, significant ST depression, and the troponin T, even to start with, is high. These are patients that really don't get a CT. These are patients who should not go for CT. These are patients to be admitted, they need to be heparinized, and they should be taken to the cath lab. Anybody comes with a new onset LBBB or an ST elevation, however mild, again is admitted and goes to the cath lab. So these are the two groups of patients that clearly don't want to take to CT. There will be exceptions, and I have two of them. I'll just quickly tell you. We had a young girl, 28-year-old, who came in cardiogenic shock with global ST elevations, referred from a hospital. And my interventionist, actually I was on duty. I was the cath lab person also that day. So partly it was my decision not to take that girl to the cath lab. And because I had no idea, she had no risk factors and absolutely fine. She had a fever history. We took her to the CT room, did a CT, and we found that she had a critical left main lesion and also features of aortoarthritis. So except for that one odd, and there was obviously another patient who had an aortic dissection with a left main involvement. These are two exceptions where I actually took patient with ST elevation MI into the CT, but that would clearly be exceptions, clear exceptions. The classic patient that I would like to take is a patient with equivocal ECG, a patient with borderline drop, a patient with not a very clear ischemic chest pain. That's the patient I like to go for CT. That's the way I would look at it.
So the next question is from Dr. Amrita Ganesh. She's asking, how difficult is it to achieve heart rate control in patients who attend ER with mild dyspnea, as mentioned in one of the cases that you presented, either because of COPD or otherwise?
Yes, I mean, a lot of it depends on operator experience, your experience with editing tools, what kind of a CT you have. It's a plain old, 64 slice. Well, it's going to be very, very challenging to deliver a good picture quality. And sometimes, you have to get your ego out of the way and just allow this patient to either go to the cath lab or just, get admitted and let the cardiologist have his way. If you have experience, you've got a high-end scanner like a 320 or a dual source, really no problem with those patients. Even without beta blockers, we have taken patients at 90, 100, and almost I've taken a patient with even 120 heart rate, given a little bit of ivabradine half an hour before taking them in and got reasonable pictures. So that's, that is a personalized decision. But I think it all depends on your experience. I think what is important, as I always say, the patient is first. We don't want to be doing a study and ending up with garbage and really not helping that patient. We've added cost, contrast, radiation, really not fair. Any situation where you think you may not be able to do a good job, the cardiologists are really good at managing these patients. We've been managing them for decades. We can admit them, take them to the cath lab. It takes 5 minutes to do a radial angiogram and we're done with it. So I think it's a personalized decision. We need to know our strengths, weaknesses. We also need to see what is our rapport with the attending cardiologist. I think that's very, very important. Because if you share a good rapport with him, even a bad study can be salvaged with him sitting with you. But if the rapport is not there, you're not going to get any more referrals, which is bad for the system. So that's my simple take on that.
Sure. So the next request is from Dr. Chandrasekhar. He's saying, can you please comment on post-bypass patients with chest pain, also in SCAD patients, SCAD patients?
SCAD would mean?
I would.
Okay, let's go with the bypass patient. So bypass is one area. I mean, it brings a smile on my face when I see these patients, because CT is so damn good. It's not only great for the patient, it's just so great for us, because in our data, we have done about, we have touched 14,000 patients as of this year. We've been working for a decade or so. Really, 40% of our patients don't come with reports. Reports, I mean the original cabbage, report with the grafts and the locations of the grafts, so on and so forth. So 40% in our series. So with that kind of a patient population, digging around those grafts in an angiogram suite takes time. It takes a lot of contrast, and it takes a lot of operator patience, let alone the patient being very unhappy. So that is one area. I mean, I would go whole hog and promote a CT as a great tool in the emergency or even in the non-emergency situation, where you want to rule out, critical CAD, for example. So a patient comes with chest pain. He's got 3 grafts. All the 3 grafts are patent. He's got bad native disease. That's it. That's the data I want with the CT, and I manage him medically. So it's a fantastic tool. I have no reservations in recommending it.
So SCAD is basically spontaneous coronary artery dissection.
Yes, patients. Yes. So this is something at the European meeting we actually talked about it, and this is a great area. We believe that CT has a role to play, because almost 20% of patients with SCAD, or spontaneous coronary dissection, especially seen in middle-aged women, that's the kind of population it comes in. Any intervention, even with the diagnostic catheter, seems to increase the spiraling nature of the dissection. And it could convert a very stable SCAD into somebody requiring 2, 3, and even 4 steps. And this was also brought out by some of the Italian speakers in the European meeting, that CT really, I think, is a great tool. The only thing is that you need to look at the data carefully, making sure you're not missing the spiraling nature of the dissection. The coronary it can be challenging, making sure you've given enough nitrate to these patients so that the coronaries are well filled, giving adequate contrast. And yes, I believe CT has a big role. Not much of data again, there's just preliminary data coming out of Europe at this point. But yes, SCAD I think would be a major area. So whenever you're suspecting it, atypical pain, persistent pain, middle-aged lady, not many risk factors, I would do a CT on these patients and specifically look for spiraling dissections.
Sure, sir. So the next question is from Dr. Mondal. He's asking, what is your practice in OPD with atypical angina patients? Would you like to do CT coronary angiography or nuclear scan? And if so, why?
Yeah, again, so my choice when I look at patients in the outpatient is as follows. So if he's a low probability patient, that means he has risk factors, the pain not clearly ischemic, he has an abnormal ECG, maybe LBBB, echo absolutely normal, and this is a patient, and he's youngish. Youngish means less than 60. No prior CAD, no stent, no bypass, no prior MI, and the echo is normal. CT would be the first choice. CT would be the first choice because you want to rule out or rule in CAD, and the rule out factor is very high with coronary CT, 95 to 99% negative predictive value. Somebody coming middle-aged, multiple risk factors, exertional angina, but no rest angina. Exertional angina, well controlled with medication. Patient has had a prior MI, patient has had a prior stenting, patient has prior bypass. That's the kind of patient I like to go with the myocardial perfusion scan, because you get a lot of functional information. If you do an exercise, you get to know how much meds he can do. You can give him an exercise prescription. But more importantly, if you look at the ischemia data, you can tell whether this patient can be kept comfortably on OMT, which is optimal medical therapy, and which patient, if he has more than 10% ischemia, actually needs to go to the cath lab and get fixed. So patients already known CAD, already had an MI, already had intervention. So they go to the nuclear scan in my practice. The only exception possibly would be the post-CABG patients, wherein I feel that because of obesity or any other reason where I'm likely to get more artifacts in the nuclear scan, or even an LBBB for that matter, I just go ahead and do a CT. Look at the grafts. Grafts are fine, not too terribly bothered with the native disease. Not terribly bothered with the native disease. And I would like to manage the native disease medical. So this is the way I would function in the outpatient business.
So a lot of people are requesting on very similar ground in checking the accuracy of CTA in comparison to an angiogram in finding atrial fibrillation, and also to rule out ACS. So if you have a common comment on this.
Yeah, AF, AF we have a pretty good experience because I work a lot with the electrophysiology group. We have a large series, so we do CTs for all their AFib ablation patients. So, you know, it's just experience and a little bit of technical skills. I do a fair job. I'm not going to say good. I do a fair job with AF patients. We know how to control their rates. We digitalize them. We give them Cordron. A lot of technical things that we do with our EP folks. But for the regular operator out there, AF is a strict no-no. You know, you don't want to be doing in the early parts of your career CTs on AF patients. The data sometimes is really bad, and you know it just spoils your reputation, lab's reputation. So that's my comment on AFib. ACS, I think the whole talk was about that. You need to pick that patient carefully. You need to know your strengths, your weaknesses. You need to know your scanner strengths and weaknesses. So you're not going to be able to do patients with a 100+ heart rate, extremely obese guy with a run-of-the-mill 64 slice scanner. Please don't attempt it. You have a high-end scanner. You have good experience. You know, is your scanner a 24/7 scanner, or is it only a 9-to-5 scanner because you're the only operator, for example? All these factors need to be taken when you want to interpose CTA into an ACS kind of picture. Because if you start doing CTAs in the night, I'm telling you, your cardiology folks will want you to do it night after night. So you better be ready to do that, because you can't just start off the program and then say, no, I'm not going to do it on Tuesday nights, but I'll do it only on Monday and Friday. So that's a little unsettling to the cardiology population. They're not going to be sending you those referrals. So I would pick a time of a place of my choice and do a good job in that thing. So in the US, there are many hospitals which just do 8 to 5 cardiac CTs in the ER environment. And it's very reasonable, because after 5, the cardiology fellow and the attending knows that, you know, he can't rely on a CTA report after 5. So he just takes them to the cath lab. Makes a lot of sense. Finally, believe me, it's just based on what you can do and you can offer, and what is your rapport with the clinician. In this case, since we're talking about chest pain, it's the cardiology person. I think a lot of it sort of factors in there, and both of you will grow. You know, I have grown over 10 years, and we've developed a lot of confidence with various people, not only the cardiologists, the pediatric cardiologists, the electrophysiologists, the cardiac surgeons. We have just developed very good thing, and they really like our imaging tool. So it takes time. All this takes time.
Okay, this is an extension to your previous comment. So how satisfied are you with CTs in ACS patients with heart rate more than 75?
Yeah, as I said, I'm very comfortable up to even 100. And a lot of care should be taken to get that heart rate down using intravenous metoprolol. If you can get a little extra half an hour time, ivermectin, beta-log combination, get that heart rate down. Even if you have the best scanner in the world, get it down. Make sure your breathing is good. Make sure your nurse is well trained and very committed to get that breathing artifacts out of the way. Make sure that the patient is cooperative. A lot of these factors will decide on the success of your scan. And yes, you will have some bad scans initially, but if you have a consistent and good program, you're going to get there. So I'm a big believer of CT in the ACS, especially in the area which I've told you about, borderline drops, borderline ECGs, the symptoms not very clearly ischemic, no ST elevations. So these are the patients that do very well with CT, and the data is with you. You get a faster discharge, you get a quicker diagnosis, and you get it all at a very reasonable cost and at fairly reasonable radiation as well.
Sure, sir. So the next question is, can we include renal angio with CTA in emergency situations where there is history of severe hypertension?
Yes, we have done those scans, but it all comes at a cost. It comes at a radiation cost. So again, it's all the rapport between you and what the referral wants. In our scanner, we switch from a dual mode to a single mode. We switch from a gating mode to a non-gated mode. Some of the 64 slice scanners cannot do it, so you've got to do gating all the way to the renals, which is really bad. It's bad for the radiation. But in case you have that capability of switching from a gating to non-gated follow-through mode, and in case of our case, a dual source to a single source, I think there is merit in that. We have done those cases. Especially in accelerated hypertension, rule out CAD situations. We have picked up a couple of renal artery stenosis also. So, it comes at a cost of radiation, but if it is acceptable to you, the patient, and the cardiologist, well, why not? Not in the guidelines, though. It's not there in the guidelines.
Okay. So there's a question from Dr. Sharda Indu. She's asking the role of GLS value, global longitudinal strain, in making decision in ED for the patients presenting with chest pain.
Yeah, so GLS is a great tool. I use it personally. And, in a difficult disease like amyloidosis, I must tell you, GLS has really helped us as a complementary thing with MR. So if you have a normal GLS in the apex and an abnormal GLS all over, it's clearly in a patient with a good LV function, it's 99% amyloid, and it goes very well with your scar burden on MR. Saying that GLS is very good, I have about 20 years of experience in the ER, and I'm telling you, GLS, forget about GLS. Even good quality echoes are hard to come by in the ER, especially if it is after 5 o'clock. Believe me, GLS is something I don't dabble with after 5 o'clock. So that's just my take there. But yes, if you have a perfectly normal LV function on the echo and you have decreased GLS, yes, possibility of ischemia is there. There is data that is available. But without a prior GLS study on the same patient, it becomes very hard to make that assessment.
So the next question is, do you use systolic acquisition of coronary CTA, step and shoot in higher heart rates to avoid delays of beta blocking in emergency room?
No, no, I don't use step and shoot with high heart rates. Clearly, I don't. We have ended up in trouble. The scans have not come out well. No, I clearly don't use that technique. Use it only in very well-controlled heart rates, very good patient, non-obese, very good breather, very compliant patient, heart rates in the 60s. That's when I use step and shoot. It's only in those patients that I've got very good results.
So I'm going to combine 2-3 questions. So these are around severe calcium and calcium scoring. So is CTA advisable, and what is the accuracy of quantification?
Yes, again, a lot of it depends on your lab and your personal experience and what you're really looking for. So I just gave you an example of 1,000+ calcium score. If it's all in the periphery, left main osteolytic osteolytic 6 is free, I would just go ahead with the CT because I know I have more or less ruled out a surgical disease. So I've done CTs for even 2,000 calcium score in the ER level, provided the left main area is clear. Saying that, if the scores cross 800 and there's a lot of proximal involvement and the patient has chest pain, uh, and it's clearly a case of a very highly probable ACS, not the totally atypical variety, I won't go ahead. I would stop at the calcium score level and preferably transfer this patient to the cath lab. But a lot of it would depend on your experience of doing many cases with 900, 800+ scores, the ability of your software to sift through. Do you have one of those fancy G machines which has a calcium subtraction technique, and so on and so forth. It depends on a lot of things. But if you just want a single answer, once I cross about 500 to 600 with left main area involvement, that is the left main region, I stop. This is, of course, in patients with ACS, chest pain, ongoing pain.
All right, sir. So Dr. Seema Rathi is requesting you to comment on retrospective and prospective cardiac gating. Can you explain that in a little detail?
Yeah. So retrospective is when your shutters are on and you're delivering radiation throughout the cycle, systole and diastole, or through a large part of the cycle, and you are able to acquire data from most of the cardiac cycle. Now, this is a safe approach, especially if you have an obese patient, not a very cooperative patient. Patient has got a high heart rate, you've tried pharmacological maneuvers, you've not come through, and also if this patient has a lot of calcium. So this is typically the kind of patient where I employ retrospective gating. It does come at a high price, a price of radiation. However, in patients who are very compliant, BMI is low, calcium scores are low, good breathers, heart rates are in the 60s, then you would use prospective gating. Here, you traditionally select a small portion of the diastole where you want the radiation to act on, and you will collect data only from that pre-specified area, region of diastole or systole, depending on what you choose. And the radiation doses are almost halved. The radiation dose is typically between 3 and 5 millisieverts here, and it goes to 10, 15 millisieverts. Again, it depends a lot on your scanner, body weight, etc. in a retrospective gating situation. But the bottom line is that if you're an young operator with not much of experience and the clinical situation demands a very accurate scan, it's a borderline patient because of the reasons I've told you. Personally, I would go with retrospective gating and just get information on all those portions of the cardiac cycle. Because you want to be sensitive, you don't want to miss anything.
So the next question is from Dr. Mondal. He's asking, how does CT coronary angiography fare against nuclear scan in patients presenting with probable chronic stable angina, and why?
Well, the short answer is you need to look at the ischemia trial, which has been published recently in the AHA meeting at Philadelphia. And fortunately for us as imagers, both have a big role. So a little bit about this trial. It took patients with chronic stable coronary disease and looked at one group which was medically managed and the other one was interventional. every patient had a CTA. And the reason for CTA is to rule out a left main or a left main equivalent disease. So when CTA had a left main equivalent disease, the patient was taken out of the trial and managed as per the physician's prerogative. Once the CTA ruled out a left main, patient came into the trial and then had a nuclear scan. And when the ischemia was, and here irrespective of the amount of ischemia, patients were stratified into the optimal medical therapy and the interventional therapy. And the results are all out, and both arms did very well. The MACE is equivalent in both. Just saying that yes, the degree of ischemia is important, and that the nuclear scan gives you that. So in our practice, if it is less than 10%, we keep our patients on medical management, provided the degree of angina also is controlled. If the ischemia burden is more than 10%, we send these patients to the cath lab to get fixed. But CT plays a huge role in removing those left main subsets. And traditionally, we know that the left main subset is a subset of high mortality, irrespective of what you do. So if you have a CTA left main and you keep this patient up to medical therapy, the mortality goes up to almost 50% in that calendar year. So I believe they are synergistic techniques. They can be used together or they can be used in different clinical consequences situations which I've already described before.
So the next question is from Dr. Kushal Pujara. He is asking, is IV beta blocker contraindicated in an ACS patient with a heart rate of more than 80?
No, IV beta blocker actually is a treatment of choice, to be honest. So beta blockers decrease the oxygen expenditure, even in a patient who doesn't need to go to CTA. So as cardiologists, we are very comfortable using IV beta blockade in all patients with ACS, irrespective of whether they need a CT or not. So beta blocker is standard therapy. And we use IV beta blockers very heavily in the ER.
So he has a second follow-up question. In case of post-CABG patients where the calcium score remains high in native vessel and troponin positive, do you still prefer CT coronary angiography?
Yes, again, it's a personal preference. There's no guideline. The guideline is possibly a 2A or a 2B. But my personal preference is I would do a CTA in that situation. No ST elevation MI, troponin T, borderline positive, chest pain. I want to look at the graphs. I get that information in 5 minutes flat. So if I have grafts all patent, and obviously I agree that the native vessels are going to be bad, it will give me two things. One is I can wait on this patient. I've got a graft patient with the patent grafts. I got the information very quickly. I can admit this patient, give heparin. There must be a thrombus which has got into one of the native vessels. Good heparinization over 24 hours, patients actually can be discharged. Or it gives me time to have a revasc strategy in place. So for example, if I find a patient with patent grafts, but a very severely diseased LCX, for example, native, and I know that the patient is not doing well with medical therapy, however intensive, I get time to discuss with my intervention colleagues, talk to the patient, arrange finances so that when we do the stenting of the left main to LCX, which is going to be hazardous, which will require a lot of hardware, including possible rotablation, I have all the information up front before I do this in terms of prognostication, in terms of finance, in terms of the material, stent, rotablator, etc. So it just gives me a very good topography before I attempt anything on these patients. So yes, post-CABG patients, I just plunge straight away into a CT. It just gives me so much information up front.
So Dr. Pujara has actually just clarified his questions. He said in ACS patient with heart rate of more than 80, if beta blocker is contraindicated because of asthma or low BP, what is your recommendation?
Yeah, so I use IV diltiazem or ivermectin.
And what would be the preferred or recommended dose?
IV diltiazem is again dependent on the heart rate and the blood pressure. If the blood pressure is borderline, I just give 5 milligrams and wait and go ahead. But I can go up to 15 milligrams if the blood pressure is stable.
Okay, the next question is more on practical use of CTA. Dr. Sanjeevani is asking how many times can one have CTA in view of radiation?
Well, there's no consensus document that tells you how many you can have. CT obviously is radiation, however you like to put it. And the less you do, we know the ALARA concept, the less you do, the better. But it again depends on the clinical context. So if you've done a CT 1 year ago, showed mild CAD, patient has come with an ACS, you don't want to take him to the cath lab, you want to have a quick rule out, I don't see any harm in doing a second CT after a year.
So I'm gonna
second CT, but yeah, there's no real recommendation, and radiation is important. It has to be a tripartite agreement with the patient, with the caregiver, and the imager.
So this is the last question we'll take for the evening. What is the role of cardiac CT in CT FFR? Accuracy of CT FFR in ostial left main?
Tough question. Actually, FFR is itself not very good in ostial left main. As interventionists, we prefer IVUS in this situation. In fact, this is one of the few areas where we find FFR is not great, ostial left main. Again, different operators would think differently. Obviously, ostial left main is not a common thing. It's definitely not a common thing in CT anyways. And with our small, pool of data on CT FFR, really too difficult for me to answer the question. But I'm sure, it has a role to play. And unlike the delicate balancing of wires that we have to do with the invasive FFR, and sometimes I know I've personally missed an ostial left main because of that, or the severity I've missed. That's why we find IVUS better. CT FFR, I believe, will be better, will be more robust. It will give you a very good idea with the, especially the distal left main is normal and it's a pure ostial left main. I think CT FFR will give us a fairly decent picture, but really not much of data to go there. And personally, I don't have that much experience. Thank you. Thank you very much.
Good night.
Good night.